I think we're going to get started. I don't know if anyone can see my slide. I'm having some trouble on the share. Can people see my slides?
Yes, we can see it.
Okay. Okay, we're gonna jump in there. So I'm Michelle Needens. I'm one of the social workers. I'm a clinical social worker here at KU Alzheimer's Disease Research Center. I work in the cognitive care network, and absolutely key, I think, in working with individuals with dementia is managing these mood and behavioral challenges. And today we're going to talk about a tool. A few months ago, you heard Dr. Townley speak on this issue, the significance of addressing these challenges. It is just impossible to separate our work in terms of cognitive function without addressing some of these issues. So we have, there was actually a prior one that myself and many of the reviewers that participated in the revision of a guidebook created a few years ago, being in 2008. And so we have updated. And so you all are seeing it for the first time, and will be available, and we'll talk about why we've created it and the use of the guidebook. So why a guidebook? Primarily because we absolutely need a tool to think through the mood and behavioral challenges. I think it's a bit of an algorithm. I think it is tough for families. I think it is complicated for providers, especially with limited time frames, to really think through all of the issues. And there's so many elements of stigma that play into how we see these challenges. For example, we see depression presents differently in individuals with dementia. And so we can miss it because of what we perceive to be depressive signs. We can make assumptions about what is typical or normal for disease process. I always use the example of repetitious questioning. Repeating oneself is common in the disease. We know that, but there is a particular flavor of repetitious questioning that indicates significant anxiety. So it's not about the behavior, it's about what's underneath the behavior. And so the toolkit allows us to replace some of those assumptions with a calculation, with a guided thought process in some respect. For families, I think it increases a sense of control. You want to facilitate somebody feeling hopeless, you tell them there's nothing you can do. And the truth is, there's always something we can do. It doesn't mean that it's going to resolve the problem. It doesn't mean that there's perfect choices. It doesn't mean that it might work and it might not work. It doesn't mean that it's a given. There's not one answer for all. So there's these caveats, but it's a path. It's something to figure out. There's not a hopelessness to it. And this, in fact, is a very key element of where we can make big differences with these families. It's more accessible, so the guide it really looks at what I would consider simplistic. Here's some of the challenges, here's some of the reasons, and here's potential interventions. That it's simplistic, it's not all narrative, which people don't read, and it's certainly not going to help families. And it can be shared with others and really facilitate therapeutic conversation. I think in many ways the guide can, the most valuable part of that is perhaps it triggers a certain set of questions. So maybe answers reveal themselves that are not even indicated in the guidebook, but perhaps the guide can facilitate an approach that includes another set of answers. So we're going to go through the guide here in a minute, but there's three distinct sections. The first one being, what are common mood and behavioral challenges? What are we really talking about? And it's just not the problematic behaviors. I consider behaviors such as isolation and withdrawal just as serious as I do agitation. Possible contributors to the challenges. So for each of those mood and behavioral challenges, we've identified possible reasons. And then the third section is possible interventions. And we will be sending you a PDF of the guidebook, which has hyperlinks all the way through. So you can click through these areas and look through potential responses. So how could we use it in some respect? So one, assistance with exploring possible considerations. So when we're stuck ourselves, it becomes a tool. Talking with family members, and that means even just printing off a page for them. You know, I think sometimes families participate accidentally, benevolently in behavioral issues and mood issues. Sometimes their communication has not been effectively altered in a way that makes sense for where the person is at the time, for example. And it's hard to hear, it's hard to know an alternative way to respond. So there's examples in the guidebook. So it's possible just to print off. It's also possible to use with care team. Some of you, for example, may make rounds in facilities. Some of you may make rounds with hospice teams or others. And so really kind of thinking through with the care team, and in fact, might even, if we have nurses and social workers on the line, it might even come in handy in terms of looking at how we develop care plans. So what we really want to do with the visual guide is to help families build confidence. That is just central. I had a family member tell me, I don't know, a month or so ago in meeting with her, and she said it so beautifully. She said, I feel like I'm in the ocean and I cannot swim. And what we really effectively want to do is give them swimming lessons. So, sometimes we can't get them out of the ocean, but we can give them swimming lessons. And that's what we want to do as we look through tools to provide them. We also know that we can't reach everybody. You and I are not enough. And if there were, 1,000 times as many people on this call, we're not enough. And there are people without access, and there are people who will not access for whatever reason. And so the more tools we can provide to the community at large, all of us, the better off we are. I think it serves as a mechanism to address family conflict. Even as professionals, sometimes families will perceive that we're joining with one family member over another. Sometimes families might even discredit us in some respect, which is okay. That's all part of grief process. It's not but family conflict is regular in this experience. People see things different. And so when we use objective external tools, sometimes that's helpful in family conflict, and sometimes it's helpful in the area of denial. I also think that it is an advocacy measure, that the more we, again, collectively, I'm not just talking about the visual guide, I'm talking about tools in general. the more we have access to educational opportunities and tools, the more we're building competency among our peers. And again, that means everyone. That's not just healthcare providers, that's aging providers, that's faith communities, that's everyone. It takes all of us to reach and respond to these families. And then contributing to empowerment of families as a whole, because again, even if the guidebook does not have the answers, which, for many situations it won't, but even if it doesn't hold the answers, perhaps it triggers the right questions for them to ask healthcare providers or whatever. So we're going to stop share for just a minute, and I'm going to share the guide and we'll walk through that. And it's not showing. Why isn't it? Hang on, guys. Oh, there we go. Me and share today. Okay, so this is the guidebook, and again, we can send out a PDF of the guide, and I want to point out, so there's some conversation at the beginning. Whoops. I don't know what's going on here. Okay, so there's some general conversation at the beginning of the guide, and then it goes into the various sections. I want to point out that a number of people reviewed and edited the document, some of which are on the call today, and special thanks to all of you who participated and edited. We had individuals from our cognitive care network. Some of the providers in our memory clinic weighed in and responded, and we had some community professionals, and I know Dr. Anderson is on the talk today, and I say thank you, who, this isn't necessarily a fun thing to be sent to review and weigh in on, and I appreciate all the work it took for all of us. So the contents, again, section 1 is the common mood and behavioral changes. And you can click through these sections to look at. So common mood and behavioral challenges, and looks at all of those components. And we're just going to, we will just pick one. So exiting behaviors. So you get to this common, so you think, gosh, the person that I'm working with is saying that their loved one is, leaving the house at night, or trying to get out of the doors of the assisted living they just moved into, or those kind of things. Let me say this before we go on. It mentions this earlier in the guidebook. This is really about middle stage. When we're talking about early stage, some of this may apply, but lots is very directed at middle and later stage. It is, these are when the highest risk of these behavioral challenges occur. It isn't early stage, so this isn't a document you'd really want to lean on in terms of MCI and early stage. This is something we created primarily for those families dealing with more middle stage. So exiting behavior, we can click on 14, and it talks about all the reasons why. So section 2 are the whys. We want to consider the whys. And that may lead us into paying more attention. It may lead us into understanding that there might be trends associated, and really thinking about the construction of days. So for example, There's all these reasons. What we don't want to do is say, gosh, everybody, if you have Alzheimer's disease, wandering is just something that happens. It's common and they need to be placed, or, make some recommendation based without the examination of contributing reasons. So they may need a different environment, but it may be something that we can resolve without having to change an environment. So perhaps we think, gosh, it's boredom. So then we can click to 34 and look at possible responses and possible suggestions for dealing with that particular issue. So we go back to section 2 and we're back on exiting. And so maybe we think, well, I don't think it's boredom. Maybe it is about anxiety. So then there's a set of thoughts. There's a set of activities to try, interventions to try in that section. So it ranges from communication changes to activities to recognizing the effect of stimulation, all of those kind of things. You heard me say, and I'm going to say again, there's no possible way that this guidebook can cover all situations and all recommendations. It is meant to provide some and to give us an opportunity to think about these behavioral issues in more creative ways, in more analytical ways, and to empower us with the questions. So again, you can go through any of these: refusal to eat, drink, and take medicine. So we think through, gosh, maybe it's about pain, maybe they have something going on. So what are we going to do? There's opportunities then to look at how we want to think about that: intermittent, dental, acute, chronic, and go through those suggestions. Maybe it's about they're not eating because they're not setting for any length of time. They get up and wander. I can't keep them sitting down. So there's suggestions and interventions in that way. So the entire guidebook goes through. So here's all the section 1 again is the mood and behavioral challenges. Which key in that will be this page 6, but also looks at some fundamental information. So why is it that we have vulnerabilities? And we look at some of those issues in dementia that cause those vulnerabilities. Why is that important? Again, if we're trying to break down some of the flawed assumptions, part of that is, families will say, well, they were always stubborn, or, they really are just trying to make me mad, or they're manipulative. Sometimes we'll hear things like that. So it does provide some general information, not just the click-through pages, but also about what's going on that leads to some of that. So there's a couple pages of that. And then it also addresses when mood and behavioral challenges are really not a problem. So you can have a divergent behavioral expression. You can have a mood challenge that I would not consider a problem, that by and large we wouldn't consider problematic. And I look at these kind of things. Is severity low? And it's not about just, does the behavior create a headache for people around them? It's also, does the behavior cause distress for the person? Are they paranoid in a way? I mean, paranoia is suffering. Being paranoid is traumatic. So what is the severity? Is it low? Does it contribute in some way to compromise quality of life? for the person with the disease, as well as the care partner or those around them, is duration limited. So if the behavior is, very infrequent, once in a blue moon, we're probably going to live with it. We're going to figure out some helpful responses, but we're not going to worry a great deal about it. If responsiveness is high, and by that I mean if someone can be redirected, if they're saying, I think, somebody's out there or whatever, and we're able to redirect them and go on about the day, then that's great. I mean, that's successful care. We're not going to worry about it. It's about when responsiveness is low. And then, as I said, distress in general. If we see severity low, duration's limited, responsiveness is high, distress factor is low, we would not consider it problematic. And in fact, we would likely affirm the support team around them that they're managing successfully. There's a few comments about the use of medications, and the gist of all of that is no magic. And you may have been on the Pocket Talk when Dr. Townley addressed this, that there is a pattern to prescribing, but all medicines are on the table if need be. And so those classes of medications are discussed. And again, these are pages that can be shared with families. So you're hearing me say this is a tool for you to share with families or to use to support your good work with individuals going through that. Then we see the variety of challenges and possible reasons. And again, click-throughs throughout. The pages themselves can be copied. We will be, we are having hard copies printed that are tinted. So could be sat at a desk and referred to if that be helpful to you. So all of those mechanisms are available to you, and we will be sending that out. We've got about 5 minutes left of the Pocket Talk. Are there questions? So there is a question about getting the PDF, and we can just send it to those people who we have the email on this call, and make sure that's sent out. We will be sending it out widely. You are free to share it. And possibly it will be shared on the website. That's a question yet. We have a question about use of Tylenol for anxiety. Dr. Townley, are you on?
I am. Yeah, I guess, it really goes down to, as you sort of went through your possible causes of anxiety, right? Well, if one of those is pain, then acetaminophen could help with that, right? But I wouldn't think of it would be a solution to all causes of anxiety, right? And actually, it's not a solution for most causes, but if there is pain associated driving some of the anxiety, then I could absolutely see how it could help. But I think that really gets down to getting a little creative and trying to find what's driving the anxiety, and then not using a one size fits all approach, right? You wouldn't want to use an SSRI medication for somebody that's in pain. You'd want to use acetaminophen, right?
Yes, and I love the question, because the question there again guides us to paying attention. There are times that, again, when we're talking about middle and later stages, that pain is not going to be expressed in the most revealing or obvious way. And so to think through how do we look at that differently, it might mean paying attention to, oral care. Are we sure there's nothing going on? And, responding in a way that guides us down a path of more clarity as to those contributing factors. So.
Yeah, and I guess I would add to that too, because some of our patients, they develop progressive aphasia or progressive language symptoms. They literally cannot voice what they're feeling as far as pain, and some lose the insight into what are these symptoms really telling me, right? The brain doesn't quite have the introspection, the ability to recognize all the incoming signals appropriately. So it is a fairly low, I mean, if there's any sense that, boy, they just feel like they're moving slower, they're they look like they're in pain, or there's some wincing even going on, but they can't verbalize it, then I think that it's a pretty good idea, right, to trial. We just recommend, kind of like sometimes we just recommend scheduled dosing of Tylenol and see if that helps. And it sounds like in this case it did. So yeah, that sounds like a good allegory there.
Yes. Okay. Other questions, thoughts? Does this look like something that would be useful to you? Yes. Good. Good. Well, we will wrap up. I just simply want to say that it's, everything we should be about is making sure that we are working as efficiently and as effectively as we can, and that means avoiding assumptions and thinking through trajectories and processes. So appreciate very much you listening to me today, and we'll make sure that guidebook is sent out to all of you. Thanks so much.